Hello, everyone. Welcome to the 198th 988 Crisis Jam. My name is Dr. Aisha Delaney Brumsey. I'm the Director of Community-Based Services with New York City Health and Hospitals Office of Behavioral Health. Really excited to be here today, and I'm excited to be able to talk to all the presenters, including Mark Seville, who'll be talking about California crisis services and their evaluation and the learnings from that. So welcome, and strap in for a great, buckle up for a great episode. This is a fantastic website. All of you are presumably familiar with this, but just as a good reminder, when you go to talk.crisisnow.com, you can register, which you need to do. You need to register for the Crisis Jam and get your own individual link, but you can also get access to all of the previous resources, find the previous episodes, look for articles. Fantastic resource to share with your colleagues in your community or to use yourself. Next slide. So we have a few different news articles to bring your attention to this week. This one's from The Guardian. They have an opinion piece or a description of how they think what it would take to fix the Mental Health Act and build dignity into our system through those actions. And all of the links for these articles are going to be in the chat. So if you're interested, just click on the article in the chat. This one's great. The North Carolina Department of Health and Human Services approved additional funding for behavioral health services. So big congratulations to the folks on the phone who are from North Carolina who pushed for this additional funding. It's always wonderful to see when a system does invest more deeply in their behavioral health services. And this article, if you're interested in learning more, this article kind of lays out what those services are and what the funding can be used for. Okay, we get to one of my very favorite sections of the 988 Crisis Jam a little bit early today. So we don't have someone who is in particular who's in the crisis trivia hot seat, but if anyone in the audience does want to last minute volunteer, this is your opportunity. But unless someone volunteers by the time I read this question, we are actually all going to be in the hot seat. Just for future, if you are interested in being in the hot seat and you get a really great t-shirt out of it, as well as just the fame and glory of having been part of the hot seat, then just email at the email that was dropped in the chat. Okay, so we are all in the Crisis Trivia hot seat today. So I believe deeply in the wisdom of this crowd. I know we're going to do this, and I know we're going to get it right. But either way, we're going to learn. So as communities across California implement specialized mental health crisis response teams to replace traditional law enforcement-based responses, evaluators began collecting data to understand the effectiveness of these alternative approaches. So, what percentage of mental health crisis calls can be resolved without law enforcement involvement when handled by mobile crisis teams? And you should have seen a pop-up come up from you. So go ahead and select. Is it between 20 and 30%, 40 to 50%, 80 to 90%, or 95 to 100%? We'll give a few minutes for all of you to put in your answers and for them to be tallied before we look to see how we did as a group. But this is also just a good question to get us kicked off to Dr. Seville's presentation. All right. Let us see how we did. All right. Okay. So it looks like about 2/3 of us thought that 80-90% of calls could be resolved with law enforcement, without law enforcement involvement. And then a little bit less than the final third thought it was 95 to 100%. So let's see how we did. Congratulations to us all. It is, in fact, that approximately 80-90% of calls can be resolved without law enforcement involvement. Some of that we believe is due to the specific training that staff have on the mobile crisis teams, their ability to diffuse tension in the situation, and the fact that they're not perceived as particularly threatening when they're on these calls. So great work, guys, and also just really great work for the mobile crisis teams themselves. Okay, next slide. So, Dr. Sevilla, I'd like to bring you up now for your presentation. Take it away.
Fabulous. Thank you so much. And yeah, so good morning or afternoon, everybody. My name is Dr. Mark Saville, and as a long-time attendee of the Crisis Jam, it's an absolute pleasure to be speaking in front of you all today. So next slide. Great. And yeah, before I get going, as always, I'd just like to recognize the amazing team that's been involved in this evaluation, not least Dr. Cameron Carter and Dr. Melnico, who are the co-principal investigators. Next slide. Okay, so today I'm going to be talking about the California Senate Bill 82, which was called the Investment in Mental Health Wellness Act of 2013. And this was an act which established a competitive grant mechanism for counties to use these funds flexibly to support crisis intervention, stabilization, treatment, rehabilitation, and mobile crisis support teams. And the primary aims of these grants are to expand community crisis service availability, to improve client experience, support recovery and wellness, whilst also reducing costs, to reduce unnecessary hospitalizations and inpatient days, and also to reduce recidivism and law enforcement expenditure. Next slide. Okay, so since the Act passed in 2013, there has been 3 rounds of funding. This particular evaluation is going to focus on the second round, where funds were distributed in 2017. So in this particular round, there were 2 tracks. There was one specifically ring-fenced for children in schools, and the second for transitional age youth and adults. So we'll be focusing on the second one. And in that second track, a total of 15 counties across California were awarded a combined total of $33 million to support crisis care delivery. And as part of the condition of receiving those funds, all of the counties were required to participate in this evaluation, which I'm going to be talking about today. Next slide. Okay, so this is just a summary of the different counties that awarded the funds, so 15 in total. And I think an important thing to highlight was that the funding mechanism has an awful lot of flexibility in terms of how the funds can be used. So the idea for that was really for the counties to be able to identify sort of the contextual factors in which they're delivering crisis services, and also be able to use the funding flexibly to kind of address what they sort of perceive as gaps in their system or areas where they feel strengthened to really kind of maximize the effectiveness and the efficiency of the crisis continuum. So while some counties focused on sort of prevention services or crisis access hotlines, the vast majority of programs really focused on either expanding or strengthening their mobile crisis assessment and triage, or the post-crisis follow-up. And by post-crisis follow-up, we mean services where individuals either didn't meet criteria for hospitalization or at the point of discharge. It would be sort of case management and support in that post-crisis phase for typically for between 45 to 90 days, with the aim of kind of supporting stabilization, sort of ensuring folks don't sort of have another crisis and re-enter the crisis system again, and ideally, hopefully link them to longer-term recovery-oriented care. Next slide. Great. And so just for sort of issues around time, I won't be able to go into too much detail on the quantitative findings, but what we did find is across 14 of the 15 programs, over 81,000 services were delivered during 23,500 encounters to 17,400 unique individuals across a 3-year period. So hopefully what should be really clear from those numbers is that a huge amount of crisis care was being delivered across these counties. And again, sort of being one of the main aims of the project were to expand the crisis care delivery. I think those numbers alone kind of just really highlight what the impact of this grant mechanism has been. Another thing to highlight is the type of services that these programs were delivering. So the vast majority were case management and outreach and engagement work. So again, it's either the prevention piece, but in most cases, it's really that post-crisis follow-up piece. So, and I think that's really important because sort of historically the conversation has been around someone to call, someone to respond, somewhere to go. Increasingly, I think, and again, this has been a big topic in this sort of crisis jam, is that piece afterwards, that someone to support afterwards, really being a huge part of what the crisis continuum is. And I think it's really notable that when counties could use these funds flexibly, this was really where they focused a lot of the work. And I think another thing linked to that in the findings was the vast majority of referrals during those spaces were for recovery-oriented services. So by far the most common sort of services that people receive sort of post this post follow-up period were either housing support or sort of referrals, and also referrals to community mental health clinics. So the idea being is kind of this lower intensity community services rather than ED wards, rather than inpatient hospitals, which is really what the point of mobile crisis care is, to kind of triage people down to less restrictive options and hopefully more recovery-oriented options. And then the last thing to say is the demographics of the population served were broadly consistent with the populations in which the programs are based. And the only sort of slight kind of area where that wasn't so much the case was serving individuals who identified as Asian Americans. So it was a slightly lower proportion in some of the counties, but the data is a bit complicated there, so we'll probably need a bit more unpacking to work out exactly what's going on. Next slide. Okay, so the focus, what I really wanted to kind of emphasize today is the qualitative component of our evaluation. So it was very much a mixed method approach. And in addition to all of the quantitative data that we collected from the programs, we also conducted a series of qualitative sort of in-depth interviews with mental health crisis providers, service users, and also collaborating law enforcement partners, because that was a major part of what a number of the programs sort of either worked with or really tried to change the system of care, sort of what was happening in these spaces. And another thing to say is when we interviewed the mental health crisis providers, we really took a lot of steps to adopt kind of a purposive sampling approach to make sure we spoke to peer specialists, case managers, clinicians, and program leadership to really get a broad representation of the work that was happening across these programs. Next slide. Okay, so one of the first things we looked at was the impact of the crisis care that was being delivered. And I think it's pretty fair to say across all of those three different groups, pretty much universally, all of the participant groups sort of reported that programs were really having a substantial impact in the areas that sort of the programs are focused on trying to address, and a lot of the areas that people say that are really important to them when they're thinking about sort of going through a crisis. So talking about things like reductions in psychiatric hospitalizations, reductions in evictions, homelessness, and suicide. Notable reductions in emergency department, law enforcement involvement in crisis care, and also improved service user and community level satisfaction with behavioral health crisis care. Next slide. And when we think about sort of some of the mechanisms that they described as to how this was happening, something that came up repeatedly, particularly from the law enforcement and the providers, was around just having a much more comprehensive understanding of mental health. So this idea of having 3,000 hours of training before you're out in the field as a mental health professional relative to 3 days that I think you get as a CIT training. So having this much better nuanced understanding, which opens up much more options, potentially sort of less restrictive options sort of in managing crisis situations. Others talked about having much more knowledge around the behavioral health system. So understanding what services might be available to individuals, what the criteria may be to engage with them, and how to link with those in the most efficient way possible. And again, sort of understanding this better system of care enabled mental health providers to link people to services that are best fitting their needs, as opposed to, oh, this person is in crisis, therefore they need to go to the ED. Another thing that came up a lot was about having much better relationships and rapport building with service users, and particularly those that experience sort of repeated crises. So a number of them talking about sort of having a much better understanding of what the individual may be going through, and having that relationship with the individual means that they were much more able to effectively de-escalate situations. And when you can de-escalate a situation in crisis, it tends to open up less restrictive care options. And then sort of linked to that, they talked about having much more knowledge of these clients. So a number of programs, a number of individuals we spoke to, talking about establishing relationships with individuals that are having sort of repeated crises. And because of that, they have a much more detailed sort of background knowledge of the individual, which then enables better assessments and care planning, which again, all of the above enables less restrictive care outcomes. Next slide. Okay, and these are just a couple of the quotes that we had from our participants. I'm going to read the law enforcement one in particular, because I think it really just highlights what the impact of having a mental health professional in the space does. I go to a call where someone says their family is suicidal and they've slit their wrists. My assessment is typically that this person is 5150, so needs an involuntary hold, and they would need to go to the hospital. Now, the crisis team doesn't always do that. They will give them options. And maybe just because they have a deeper understanding of what the behaviors are causing, or they've dealt with this kind of stuff in a lot more extensive manner, but they won't always place that person in a hold or take them to hospital. So again, just really highlighting that better knowledge and nuance and understanding of what mental health crisis is can open up these different options that may be better fitting the need of the individual. Next slide. Thank you. And in addition to looking at the impact of mental health crisis care, we looked a lot about kind of the barriers and facilitators to effective crisis care delivery. And this kind of work has been something we recently submitted and actually just got accepted for publication on Monday, which is awesome. So we've finally got the final proofs. So it should be something that should be coming up very soon. So if this is something you're interested in, it's something you can hear a bit more about in the near future. So next slide. Great. So the first thing we looked at was the barriers to effective crisis care delivery, and sort of three consistent themes that came up. So one sort of represented in client level factors, the second program level factors, and the third these kind of broader system level factors. And one that came up a lot with the client level factors was service user ambivalence, particularly around that post-crisis follow-up. And something that came up a lot was the idea of individuals that have been burned either by the mental health system or the system more broadly, feeling much more on guard or defensive or unsure about what this service is and whether it's actually going to address their needs. So that being an area that the mental health professionals sort of in the crisis teams having to work very hard to develop that trust, to kind of maintain that kind of link between sort of ongoing integrity and sort of support for service users to actually engage and trust the system and trust the care. Others that came up a lot was issues around homelessness. A lot of the folks that were receiving these services were either sort of in sheltered or unsheltered housing, and that can be a lot of challenge in terms of just firefighting and basic needs, but also logistic things, so just like the lack of a phone or the fact of constantly losing a phone, meaning it's really hard to maintain engagement with that individual. And then a third thing that came up a lot was challenges around substance use, and particularly individuals that were actively using it, kind of leading to people wanting to focus more on addressing that need as opposed to engaging in care. With regards to program level factors, the thing that came up by far the most was the challenge of recruitment and retention of providers. And things that came up, I mean, as we know, I think recruiting and retaining providers is difficult across the behavioral healthcare landscape at the moment, but they were talking about it being particularly difficult in crisis care because of sort of typically the unsocial hours, the increased risk and liability of this kind of work, the fact that it's very field-based, so not having an office, kind of being out in the community a lot more and being in spaces that can sometimes be quite challenging. And then also the very short-term nature of the work, sort of a number of providers talking about a preference for working sort of much more longer-term recovery-oriented work, sort of what people wanting to do. So them talking a lot about it being a real kind of special person that wanted to work and stay in crisis work. And then another thing that came up a lot, which again is certainly not exclusive to the crisis care at all, but it's just the excessive paperwork and bureaucracy, and that being a real kind of source of frustration and burnout for folks that are working in this space. And then the sort of the more broader system level factors that came up. So one that came up a lot was the lack of wider service availability, and particularly psychiatry and housing services. So a lot of folks they're seeing, again, being in sheltered or unsheltered homelessness, so needing that housing support, and there just not being the resources there to support individuals. Others being psychiatry, sort of needing to establish meds or be on a regimen that works for them, and then just not being able to have those appointments. And the problem with that being it could lead to dissatisfaction with the crisis team itself because they weren't addressing needs, which then in turn can lead to disengagement, which then can perpetuate that cycle of kind of repeat crises. Other things that came up were the challenge of care in rural communities. So while some sort of identify the positive aspects of working in rural communities and particularly kind of having much better knowledge of the individuals and the services that are there and having these kind of personal relationships because it's less people that kind of trying to navigate. Others talked a lot about some of the challenges too. So things like having much longer distances to travel, so the delays in being able to respond appropriately, or the inefficiencies of having to drive long distances to see people. Others talked about kind of isolated areas that can be quite dangerous if they don't have cell phone service or places where they can sort of escape in these kind of rural spaces if they need to. And then others about the challenge of just developing trust in these rural communities that perhaps aren't so used to outsiders coming in and trying to sort of support others. And then the final thing that came up was around state and county policies. Next slide. One of those that came up a lot was, which was quite interesting, in some counties, crisis care could be provided by the mental health professionals alone. In others, there was this county mandated co-response. So mental health professionals couldn't attend on the scene without law enforcement being present. And I think a number of the counties that had that law policy in place really struggled with it. And I think it's best typified by this quote here. we don't yet have a system in place for if law enforcement doesn't go out on these crisis calls. And my thoughts are we should. We should. It's not okay that law enforcement is going out in situations, in my opinion, where it's a situation that could be handled by a social worker. And in addition to that quote, I'm just going to read the previous one as well, because I think it's one of the most evocative ones as to what the real challenges of doing this kind of work is. So this is talking about one of the first providers we spoke to, talking about some of the challenges in recruitment. I know a lot of people don't want to do this. It involves rolling your sleeves up. You get dirtier. You see people's terrors. You see people's sweat. You smell them. You're involved with people who are intoxicated. It's a lot of variety. And my experience is that a lot of therapists, they just want the comfort of an office where things are relatively neat and tidy and there's no surprises. Next slide. Okay, so sort of the final piece I'm going to talk about now is some of the facilitators to effective crisis care. And again, 4 themes really came up. So one being the provider approach to care. So being very aware of the power dynamics at play where you're working with someone who could potentially have their liberty taken away. The importance of being very client-centered and client-oriented, like particularly in cases where people have been burned by the system and trust might not be there, kind of really centering the experience on the individual can be a really important way to provide effective care. Others talked about things like really simple things, just like addressing basic needs. So there were some that had food and water in the trunk of their car and talking about how that can be a really powerful way to address immediate basic needs and sort of set the dynamic between them and that individual in a positive kind of way from the outset. A lot of them talked about the importance of the client support system. So family members, loved ones being really key in supporting the assessment process, creating sort of viability in care planning, which can then sort of open up less restrictive options, and also being an important support in that post-crisis follow-up piece where they're trying to link individuals to longer-term care. Another piece that came up was around the optimal crisis service structure. So about 40% of our programs recruited peers, and everyone that had peers really highlighted the key role that they can play in terms of stigma reduction, fostering trust, helping to support that collaboration and kind of providing hope to individuals that may be experiencing a crisis. Others talked about the extended hours of operation. So importance of being open at weekends and evenings, and when they're not, that really just then falling onto ED wards and law enforcement staff to pick up the slack. Others talked about the importance of field-based service delivery. So certainly the mobile crisis by definition needs to be field-based, but also that post-crisis follow-up piece as well. So if you want to support and continue engagement with individuals, then it really needs to be out in the community. And then the last thing that came up was around the team-based approach to crisis care. So recognizing this is a highly charged, stressful work that can have very high burnout associated with it. So having very strong supervision and mentorship, adopting a real team-based approach can be really important to mitigate some of the burnout that can invariably come with this kind of work. And then the last thing being sort of the key role of collaborating partners. So law enforcement partners, ED staff, other mental health professionals, park rangers, sort of how essential it is to really embed yourself in the community and establish links and relationships with these folks to support referrals into your program, support effective care delivery during sort of the crisis period, but then also being somewhere where they can effectively link individuals to afterwards and when they're ready to move on to more recovery-oriented care. So next slide. Okay, so this is the one about just addressing immediate needs. Again, something very simple, very concrete, but a few different people spoke about how powerful this can be. A lot of what I see, finding food is a really immediate need and will reduce a lot of the crisis because people are hungry and thirsty. And once you meet that need, I travel with food in my trunk. And once you meet that need, all of a sudden people calm down and you can really start looking at, okay, long term, what are we going to link you with? Next slide. Okay, so that's kind of the headline findings. We have a report that we submitted to the Oversight and Accountability Commission who funded this, which has much more in-depth kind of summary of what happened to kind of give the high-level piece. So the first thing is $33 million invested in this tranche led to 81,000 services to 17,000 clients over a 3-year period. So a lot of care being provided. And most of those service users who received such care were referred to lower intensity sort of community behavioral health and housing services. A lot of the individuals we spoke to, providers, law enforcement partners, and service users really highlighted the positive impact that these programs are having. Next slide. However, a number of barriers were identified to delivering this kind of care, particularly the client program and system level. And in the the report, there's a bit more information around sort of how these different groups thought about best ways to mitigate some of these challenges. But then also, sort of a number of solutions were offered and facilitators were offered too. So, for example, the importance of the provider approach being client oriented, importance of collaborating partners, so developing these relationships early to really kind of embed you in the community and sort of have this something that can be effective. The critical role of peers, sort of about improving engagement, destigmatizing mental illness, and fostering trust. And then that last piece about being field-based with this extended hours availability to really kind of meet the critical needs of the community. So as I said, this is kind of just a very high-level summary of what we did. There is much more information in the reports, which I sort of welcome people to look at. And if there's any questions or any sort of follow-up issues, I'm more than happy to reach out and I'll address those as they come. So thank you.
Thank you so much, Mark. Really appreciate it. So we're going to call up our discussants for the roundtable, but just to flag, there are a couple questions in the chat. If we have time at the end after the discussants, I'll bring them up. But if not, Mark, if you're sticking around, you can also respond to those as well. That'd be great. And folks in this call, I know this is also like a group with a lot of questions, so feel free to drop them in. We will get to them as we can. So first, I'd like to bring up Kristen Love Clark, Crisis Program Supervisor with Placer County Behavioral Health. And I should say, everyone on the roundtable, you have about 3 minutes-ish for your reflections. Thank you.
Hi, good morning. Thank you for having me. My name is Kristen Love Clark. I am a program supervisor for Placer County Behavioral Health. I've been working with the county and specifically with the crisis program for about 10 years, and the supervisors for about 4 years. Very brief kind of background about Placer County and the mobile crisis specific services. So we actually got our first SB 82 grant in 2014 and started mobile crisis with 2 teams. We were just working with 16 and above, and our referrals initially just came from law enforcement. And then as of today, we have now, it's 24/7. The state mandated, the idea of having 24/7 starting in January, but we have upwards of like 6 teams, all ages throughout the county. And then our 6 teams are pretty much from 8 to 8. And then we have 1 or 2 teams that work the overnight shifts. So we've definitely grown. When we first started, mobile crisis consisted of a clinician and peer advocate for the first couple of teams. And then kind of what I'm going to focus on today is how we've continued to expand. So now we have family partners, counselors, clinicians, peer advocates, and then we also have a psych nurse. In 2019, our SB 82 grant, the second round, we actually introduced the concept of having a psychiatric nurse as one of the as someone who could join one of the teams, which was pretty unique. We weren't entirely sure how it would play out, but the idea was to see what we can do about providing medical care, medical oversight, physical care, perhaps to clients that we're seeing out in the community. And it's actually been a huge benefit. So the idea was we've been definitely seeing more and more clients under the influence of substances, under the influence of alcohol, sometimes with a lot of complicated medical concerns. Sometimes, an increase, and this was a little bit before COVID, and I definitely want to say after COVID, an increase in elderly in regards to mobile crisis. And so the introduction and the availability of having a psychiatric nurse has helped with providing a different kind of assessment and evaluation, and additional services to a variety of clients with those complicated situations. One of the things and the benefits that they can do is if they go out, they can kind of rule out some medical needs. So whether it's immediate needs, they can rule out concerns, if with intoxication, with withdrawal, whether that's something where they need to go to the emergency room right away, or even kind of to assess and evaluate to determine if that's maybe contributing to some of the presentation. The other thing is, like I said, with the increase in elderly population, and we go out sometimes to assess people who are in their 80s and 90s, and so there's sometimes situations where perhaps this is related to dementia or cognitive decline. Law enforcement family, right? They call for assistance with evaluations and providing services, regardless of whether it's mental health or whether it's dementia. And so when we have a psychiatric nurse, sometimes that is something where we can do additional evaluation and rule outs and get people the help they need. The other aspect is this helps kind of with the overall evaluation. If someone does need to go to the emergency room or to the hospital because of a medical concern or a cognitive concern, we can assist with the triaging to get them to the ER. Sometimes we can avoid a hold. I mean, in some situations where we've had law enforcement, they go out and they put, 92-year-old dementia lady on a hold and bring them to the ED to sort out, where we can alleviate that. And assist with voluntarily admission to the ER, or just going in an ambulance, and then we'll follow along and go to the emergency room and do that sort of communication with the social work team or the crisis team, and sort of so they can bypass that kind of crisis evaluation or lifting of holds.
Kristen, Kristen, I'm so sorry. I don't mean to cut you off, but just one final thought, and then I've got to pass it along.
Yeah, no, for sure. And then the other aspect is follow-up appointments and safety planning. So a lot of the time when we have a psychiatric nurse and we're trying to get a hold of medical doctors or psychiatrists, they're more willing to have a conversation with another medical professional and a nurse to have conversations about medications, appointments, versus a social worker or a clinician kind of calling to schedule that appointment. And so we've been able to facilitate that and have that communication a little easier and quicker when we're trying to do follow-up appointments and safety planning. So that's something that Placer County did in 2019, and we still have one today. Actually, we've had up to like 2 psychiatric nurses sometimes, and she also helps part-time with APS now. And so we've kind of expanded her role as well.
Thank you so much, Kristen. It's amazing to hear some of the great work you're doing, and I appreciate you really highlighting the fact that having these multidisciplinary teams can not only work better within the system and help make work the system more flexibly, but also really support the multiple and overlapping needs that the people your teams are working with have. So thank you so much for that. Matt Goldman with Kings County, welcome. We'll pass to you.
Good to see you, Aisha. And thanks for the chance to be here. So Matt Goldman, I'm based here in King County, Seattle area, but I had the good fortune to get to be a consultant on this work. And so got to work with the evaluation team, and just Mark, so exciting to see you get to share this here. Fantastic work. You've done just amazing work making this all come together. What I want to highlight from this is actually taking a step back. Many of you have heard me kind of get on my soapbox and say, we need more crisis services research. We need more information and evidence to support implementation of these services and programs across the country to really understand best practices, to make sure that we're doing sort of the best version of this care possible to best serve folks who are in crisis. And this is a great example of how to develop the evidence base for crisis services. So this was, California putting a huge resource into the implementation of 20 programs across many different counties really getting to lead the type of program that they were implementing, doing so, through county leadership and communities speaking up about here's how we want these programs to go. And then critically, the state investing resources in meaningful evaluation. So often the evaluation part is sort of an unfunded mandate that comes just as also you got to make sure that you tell us how it all goes, but there's no actual resources to figure out how to do a high quality evaluation. That was not the case with this SB 82 project in California. There was significant resource to fund Mark and the whole research team to be able to really use rigorous mixed methods, quantitative data collection, qualitative interviews with a range of different participants and partners, and to get this meaningful information that now Mark can share with you all here today, everybody can learn from, going into academic publications, and then critically informing the state in its future work. So often when government programs, especially high visibility ones like crisis service implementation, which often elected officials are directly involved in making these things happen, there can be a nervousness about, well, do we really want to study it? Because what if what we find is that it didn't work? And that could have political ramifications or some sort of downside. I just want to applaud Tom and MHSOAC in California for taking the leap and saying, we want to understand what happened. And even if there were things that happened that weren't perfect, nobody's perfect, but we got to learn from what we're doing here. We got to understand what implementation looks like so that then we can roll out these services better for the long term and in the future to then be able to improve the quality of crisis services down the road. So just want to highlight this as an example and encourage all folks out there, however possible, funding evaluation and research into crisis services is a sort of essential bedrock for us to be able to move this field forward. So thank you.
Thank you so much, Matt. Thanks for a reminder that it's important to do the work, but it's equally important to really learn from it and not leave that knowledge sort of to die on the vine and not inform the future. And I think that's a perfect transition to Tom Orrick with MHSOAC. So I'll bring you up, Tom.
All right, thank you. Thank you, Dr. Goldman, Dr. Saville. And it's been great to be part of this program. It was really the first thing I got involved with when I came to the commission. So I'm the deputy director of the state's Mental Health Services Oversight and Accountability Commission, and we administer the SB 82 grants, and we've done that in a couple of rounds. Round one back in 2014, I think it was, and then before round two, we heard from child and youth advocates that there wasn't enough of this funding dedicated to children and youth who are in mental health crisis. And so we looked at that and they were right. It was about 17% was dedicated to children and youth programs. So the commission changed that up and required that at least 50% of the funds be dedicated to children and youth. And then also, they did a very important thing. I think looking back in 2017, they took $20 million of that investment and decided to focus it on school-based mental health and crisis support services there as well. So $20 million funded 4 programs to really drive partnerships between behavioral health departments and school districts, county offices of ed, and any other partners that needed to be at the table to help children and youth in schools. And so that led to the Mental Health Student Services Act, which is a $280 million program. We have it in 57 counties now. So that was a nice little shift toward getting services to students. Just want to talk a little bit about that tendency for us in the state and elsewhere to be concerned about what if this doesn't work. And I think the nice thing about the commission is that we also oversee the innovation funds through MHSA, and in BHSA, we'll be overseeing the $100 million investment in innovation, the Innovation Partnership Fund. And I think in doing that work, it kind of gets into our blood here that we need to be innovative if we're going to do things differently, especially in crisis, and build a crisis continuum of care. And it's okay if innovations don't work out exactly like you think they should. In fact, sometimes it's better because then you learn how to fill gaps, and that's what we do with a lot of our funding is we invest it in services, of course, but we also want to keep an ear toward why is this not working? And I think with our triage program, SB 82, we realized that it really wasn't addressing the boarding of people who are in a behavioral health crisis who are stuck in emergency rooms for a day or 2 days, sometimes even longer. We also recognize we have a significant workforce issue in this area, as Dr. Saville talked about. And so, it's really nice to do this, and it's great if it works perfectly, but it rarely does. And I think we have to be ready to learn from the things that are not working so well. But it's been a great partnership with UC Davis and UCLA. Very happy to be connected to this work. And we have shifted this funding a little bit now that more mobile crisis teams are being implemented across the state. We decided to take a lifespan approach to crisis response and early intervention. And so we launched an older adult program, a mobile crisis program for older adults, the Empath unit project, which an Empath unit is a behavioral health crisis services or emergency unit within a hospital. So we're launching 11 of those around the state to see if we can deal with the boarding issue. And then also SUD teams to provide MAT services. And then our next one is 0 to 5. So we're going to focus on the 0 to 5 population and crisis and early intervention related to that population. So thank you very much for the opportunity to speak.
Thank you so much, Tom. And I really appreciate the fact that, if you're innovating, things are not going to work. And that's actually a good sign, because you're trying a lot and trying things that you might not have thought about. So thank you so much to all of our discussions. Thank you so much to Dr. Saville. This was fantastic. It was great to learn about all the fantastic work that's going on in California and what is working well and where some of the challenges lie. So appreciate it. All right. Next up, we have Dr. John Palmieri for the SAMHSA update. John, please.
Hey, Aisha, good to see you. It's been a bit. Hello, everyone. Happy to be here. Just wanted to provide a couple of updates from SAMHSA. One is that our new, our Crisis Systems Response Training and Technical Assistance Center has a new webpage, which may not sound that exciting, but it actually has been a long time coming. So it's very positive news for us. And I'll throw the link in the chat, that has a growing list of resources. You can find upcoming events there, our monthly newsletters, etc. And just by way of upcoming events, just as a reminder, tomorrow there is a webinar as part of our Children, Youth, and Families series, where there's still time to register for that. And you can find the registration link directly from that same page. And then also flagging as a reminder, the deadline for Policy Academy applications is November 27th, so 2 weeks from today. And that again is intended to be for state, territory, tribal nations forming teams who are interested in working on any particular goal that they identify with respect to crisis systems design challenges in their communities. That will be, the actual Policy Academy will be held in New Orleans in March. And as with the first cohort, there'll be some pre-Policy Academy virtual meetings and then some follow-on activities after the convening in March as well. And then the other thing that I wanted to just flag for the group is, I'm not sure if this has been mentioned before, but CMS did post their final rule for calendar year 25 in the physician fee schedule. And there are some very positive changes with respect to a standalone code for safety planning, and then also a monthly bundle code for follow-up activities following crisis encounters. So that I think is a move in a very positive direction. People who did provide comments to CMS may remember that they also did invite some comments related to crisis stabilization services. They did not include that in this final rule, but did say that they would consider those comments for future rulemaking. But I think in terms of safety planning and follow-on activities, I think this is actually a lot of progress. So good news on that front. And I think that's it.
Thank you so much, Sean. Good to see you as well. There's a couple, I think, some questions in the chat, but I know you're going to drop the links in because that's what they're for. So thank you.
Okay.
Next up, we have Dr. Deb Pines with the NASHBID update.
Hello. Nice to
Hi.
see everybody. Hi, Aisha. How are you?
Good.
That's great. So I think we have some NASHBID slides. I just want to make sure those got in. And it's great to be here on the Crisis Jam. And if there aren't, that's okay. I'll go without the slides.
I think you might have to.
Okay. All right. So what I want to talk about is just a preview of coming attractions. We have our papers that we promote and that at NASHBID we work on behalf of SAMHSA, and hopefully people are aware that the Connected and Strong series was just released, and you can Google Connected and Strong and SAMHSA and see that, and that's part of the Beyond Bed series that we work on. I serve, one of my roles is as editor-in-chief at NASHBID, and I work with my partner, Elizabeth Hank, to put the papers together. So this year, we just wanted to highlight what's been picked, what we're working on for 2025. The 2025 papers are going to really be about refreshing our knowledge and refocusing on some basics to build out that continuum of care that goes well beyond just having inpatient beds available. And we've been working so hard on crisis services that SAMHSA and others just thought it was good to take a step down and out and back to just the basics. So who we serve and how we deliver services is really kind of the goal of these papers. We're going to have a section on children, youth, and young adults, where we'll have some experts writing what we know about serious emotional disturbances in children, youth, and young adults, prevalence rates, the kinds of conditions that we're seeing. And then we're going to have a paper on multi-system involved youth. We know that the multi-system involved youth, those involved in child welfare, those involved in juvenile justice, the behavioral health system, Medicaid systems, can have a whole range of complex needs. And to better serve them, we have to really understand who they are and how the systems intersect, sometimes neatly and sometimes not so neatly, that impacts the care that's delivered. Then we'll have a section on adults, looking at adults, and give you all the latest on schizophrenia spectrum disorders, what the science is telling us, what we know, what we still have yet to learn, and what are the latest in treatments for these with all the new psychopharmacology that's coming out. Eating disorders is going to be another area of focus. We're really excited to be partnering with the section in SAMHSA that focuses on eating disorders. This is a really important area. Although it's a small population, it can be a population that public mental health leaders and providers struggle with. So we're going to provide the latest information on eating disorders. And then we're going to talk about maternal mental health using the national strategy. Such an important area. We have to think about the individuals we serve as parents, and in this case, we're going to focus on maternal mental health and what that means for development and what that means for ongoing parenting. And that'll be an exciting paper looking at the national strategy. And then we're going to have a section on the mental health systems, how we deliver our services. So a systems-based approach to supporting children, youth, adults, and older adults, really looking across the continuum, across the system to see how we're functioning as a system, sort of in that systems of care approach that we have for kids, really looking at it across the lifespan. The evolving landscape of state hospitals. There was a paper looking at the vital role of the state hospitals, I would say back in just before 2016, maybe 2015. And it's been almost a decade since we've written about what the role of state public hospitals are, state mental health hospitals, and how those have evolved, many of them becoming more and more forensic, but also just serving a basic function for the states. And then we're going to have a paper.
I'm so sorry, Deb. I hate to cut you off, but just like one final thought, and then
okay. Legal interventions and then forensic issues. So stay tuned. We have more to talk about, and you'll get to see more as those appear. Thank you. Thanks, Aisha.
Thank you so much, Deb. Those are always such fantastic resources. I really appreciate it. Next up, we have our federal updates. Joanna and Sarah, I'll turn it to you.
Thank you. Yeah, I think Sarah was going to go first and give us a roundup of the election results.
Thank you so much. So yeah, I will start on House and Senate updates and where things are looking as of now. On the Senate side for the next Congress starting in January, it looks like the Republicans will have a 2 to 3 seat margin for their incoming majority, depending on which news outlet you're looking at, depending on who has called the races. We actually have some breaking news that Senator Thune of South Dakota has been named the new voted as the new incoming Senate Majority Leader for the Republicans for next year, starting in the 119th Congress. On the House side, there are still many votes being counted on some uncalled races, but it's looking like it will be a slim majority also for the Republicans in the House, but we still do have a few more races that need to be fully counted before we have the kind of end margins, but it's coming down to a few races that are still being counted. On the leadership positions question, I believe they will be having their vote tomorrow for some leadership positions in the House. And then from there, we'll start to get more information about committee assignments and other kind of outstanding questions around what the 119th will look like. One quick caveat, it looks like some names have been floated or named officially from the House or Senate for incoming cabinet or agency positions, which could affect the ultimate margins between the House and Senate. But we'll have to wait to see how that unfolds as we get a bit closer into to 2025. Joanna, I'll flip it back to you.
Thank you. Yeah. And so what does this all mean for us and for 988? As we sort of head into the end of this year and look towards the 119th Congress next year, we have sort of two outcomes that we could possibly see. There's a chance that on the one hand, the Republican majority wants to finish up business at the end of this year and sort of start fresh in the new Congress. And that would mean they would hopefully pass an FY25 budget by the end of the year, and we would see that come through. And hopefully, we would see what the levels are for 988. We'd report that back to you. On the other flip side of things, we could see that the majority wants to sort of hit pause and come back and start to make their decisions on how things will be passed over the next session. So there is a chance that we could get another CR for the budget, which would mean that we wouldn't have final FY25 numbers until we're into calendar year 2025. So that could also happen. So we'll either see, hopefully, I think most people would prefer to see a full budget passed at the end of this year, but we will see about that. There could be a CR. And then also there might be some packages coming through. The Support Act package is one big one that a lot of health groups have been following. And we'll see if that gets passed by the end of this year. Again, if not, we'll see them pick up where they left off in January. And I'll cap that off there. Hopefully we'll have some more concrete updates for you in the future.
Thank you so much to you both. Really appreciate it. Definitely a lot going on at the federal level. Next up, we have Lived Experience Library. I believe we have our fearless leader, David Covington, here to talk with John Brogan. And David, you know this better than I do. We're running a little tight on time, so if I could just give you a couple minutes.
Yeah, thank you so much, Aisha. And John, thanks for joining us at 4:30, whatever it is in the morning there in New South Wales. John, such an amazing political, business, and mental health leader. And John, thank you for sending me the book. I'm going to open box it. Tell us about Profiles in Hope, John, and why you wrote this book. John?
Hello, can you hear me now, David?
Yeah, come on, John. We hear you.
G'day. Hello, everybody. Yes, it is 7 minutes to 5 a.m. here in Sydney, Australia. But if David Covington asks you to do something, you can only but say yes. So I've recently published this book called Profiles in Hope. It's a direct homage to President Kennedy's 1956 book called Profiles in Courage, where he wrote about 8 well-known statesmen in the United States who had acted courageously in public life. This book is about 15 Australians who share their story of suicidality, of planning to take their own life, or indeed, in a couple of cases, of people who attempted to take their own life but survived their suicide attempt and lived to tell the story. We all know that none of us can tell the story of somebody who fully tell the story of someone who completes their suicide. But I wrote this book because our objective, I think, as a sector, as people who care, is that we normalise mental illness, that mental illness, anxiety, depression is simply another illness of the body and should be treated as such, and the stigma that's associated with it should not be there as a consequence. In contrast, I don't think we want to normalise suicide from the perspective that we want people to live. We want them to not kill themselves, to survive. And part of that is a message of hope. So these 15 stories are of some famous Australians, very high-profile sporting stars. They are of some wealthy Australians, they're billionaires and the like, a couple of an existing politician, a senator, a former senator, as well as some people who are unknown to the public, but whose stories are quite extraordinary in terms of giving the message of hope that there's a way through difficult times.
John, this work is really transforming our views, and thanks so much for sharing your story and these, and we'll look forward to talking more about it in future Crisis Jams. Maybe you can come back and do another feature with us.
Sure, love to. Thank you.
Thank you, Aisha.
Thank you so much. Next up for our, we have Crisis Talk with Paul Galdis. Woo. Sorry, Paul, and Stephanie Hepburn. And I'm going to give you guys just like 2 minutes. Sorry.
That's okay. I knew it was going to be tight. I'll bring on Paul. He is my colleague and he's RI's Deputy CEO. Paul, can you share with us how the 7-Step Parity Action Plan helps providers receive payment from commercial insurers?
Yeah, thanks, Stephanie. Thanks, Aisha. Look, I think the important thing here is it gives you a straightforward process, whether you're a provider, you're a state administrator, others, of how you can get commercial payers to start paying for crisis care. And those of us that have relied on state general funds, grant funding, or other things to get things started over the last few years, it's a fantastic jumpstart. But we can take 70 to 80% of what we're paying as a state or a county and actually push that to responsible payers and the federal match that comes with Medicaid. So the 7 steps are pretty straightforward. And the thing I'll say, Stephanie, is thankfully, due to the generosity of the Socialze Foundation, we have funding available to walk you through it. You'll see my email contact in there. And look, it all starts with submit a claim. Ask that commercial payer to pay for it. And if you get a no, we actually give you examples of appeal letters that you can use, claim forms, attachments that you can show to explain what these services are, and really designed to focus on emergency behavioral health crisis care, Stephanie, which means a mobile response we say is completely analogous to a community-based emergency medical response or an EMS response. And so therefore, if an insurer pays for that, the expectation is they will pay for mobile crisis. Same is true for those no wrong door crisis facilities. They're very analogous to the emergency department. So there are tools in there, there are sample letters, there's contact information, and just happy to help anywhere we can, including meeting with Department of Insurance to help them get a jump start on how do we push, how do we make a case that these should be paid. And I think it's clear enough. We've had over 15 years of this has been the law of the land. So I think it's time to get everyone to start contributing their share instead of relying on local taxpayers.
And just last question, what should legislators be thinking of when they're building out their budgets to help support providers?
Yeah, so there are a number of things, but I think the first is, look, we start with state Medicaid publishing something on this, because if I go to a commercial payer and they say, how do we pay for it? What's the coding? What's the expectation in the state? And if that's not been delineated yet, then it's a bit of an upward battle. It doesn't mean it can't be won, because this is still what should be a covered service. And so there's a path. But if states have taken that first step, publish solid rates that align with the cost of services, what happens is the states stop paying for what we call, in so many cases, you're either Medicaid or you fall to the state general fund budget. And in fact,
most of those are commercially insured individuals. So this will actually represent a huge drop in the cost to states and counties when you get others to pay for it, and really does lower the overall cost of care. So the toolkit's really easy to use, but happy to walk anybody through it or provide guidance or join any meetings.
Thank you, Paul. Pass it back to you, Aisha.
Thank you.
Great work. And then Vic Armstrong, bring us home with Strong Talk.
Thank you so much. There are times in life when we're faced with a choice. The choice being to keep your head down, keep your mouth closed, and keep moving forward, or to lift your head high, stand tall, and lead. This moment is such a time. Over the past several days, I have heard some who lament last week's election results and others who celebrate. Whatever your position, the fact is that we are in many ways a nation divided. While we may disagree politically, one fact remains. Our success or failure as a nation, our survival going forward, is not contingent upon who sits in the White House. It never has been. Our fate rests upon what we do individually and collectively to make the world better, and our being cognizant that we are all bound by our humanity. Our Creator gave us this earth. We drew borders to separate ourselves. We separate ourselves based upon proximity and pigmentation. We separate ourselves based upon ideology and political leanings. And we measured each other based upon the accumulation of wealth, power, and people, when the only true measure of an individual or nation is how we care for the least among us. We are a nation built upon the synergy of our differences. Differences that, when harnessed, make us stronger. It's understandable that we will have moments of disagreement, even anger, but our diversity of thoughts and ideas are what make us great. When we rally together as Americans, Black, white, brown, Democrat, and Republican, we are strong, and we are the beacon on the hill. So as we navigate our path forward, my advice to all of us is simply this. Look within yourself and seek truth, not political affiliation or popularity or power. Look to your moral compass that always points toward life and liberty. Let that be your guide. If you are a person of faith, person of prayer, pray for truth, not affirmation. Pray for wisdom, not confirmation. If you rely on your Bible for guidance, seek guidance to do that which is right, and not justification to do that which is expedient or prosperous. And if you stand for the rights of all people to be granted freedom from oppression and equal protection under the law, regardless of race, culture, ethnicity, sexual orientation, gender identity, or diagnosis. I choose to stand. If you choose to stand as well, you may not know what to say, and that's okay. You may not understand my passion or my pain, and that's okay too. Just stand with me anyway. I feel stronger just knowing that you're here. If you can't find the words, I will lend you mine. I will live and let live, love and let love. I will show compassion toward and advocate fiercely for those who are less fortunate than I. I will laugh every day and bring a smile to someone else, even in the midst of my own pain. I will find joy in the moment and hope for the future. I will love my Creator, I will love myself, and I will love my fellow humans. And I will leave this world, not just my corner of it, a better place for my having been here. And that is Strong Talk.
Thank you so much, Vic, for closing us out with that wisdom. That was fantastic. Thank you all for being here today. Just really quickly, next week, a focus on Indigenous identity and queerness and intersectionality there. The following week, Thanksgiving week, we will be taking that day off. So enjoy that time as well. And then we have a focus on CIT for youth coming up when we return on December 4th. And then our next debate, Crisis Peers. The debates have been quite popular, so do tune in for that. Thank you all for your time. Looking forward to seeing you here next week.